Welcome to our channel Medicine Demystified MD. We are discussing last minute pearls for NEET PG in the subject of gastroenterology. So dysphagia and odynophagia are esophageal symptoms. Melena hematemesis are upper GI symptoms. So melena and hematemesis is upper GI bleeding. Melena is altered blood through the stools, that is black tarry stools. Hematochezia is fresh blood through the anus. So hematochezia indicates a lower GI pathology. Melena indicates an upper GI pathology. So about diagnostic colonoscopy, a therapeutic colonoscopy and diagnostic colonoscopy. So what are the uses of diagnostic colonoscopy? It is used for cancer screening. That is very important point. And one of the evaluation of anemia should include diagnostic colonoscopy, and diarrhea evaluation also should include colonoscopy, because diarrhea is actually a small intestine or a large intestine symptomatology. Like dysphagia and odynophagia is for esophagus, diarrhea is for either the small intestine or large intestine. Now what is capsule endoscopy? So we have upper GI endoscopy, which visualizes the esophagus, stomach and the up to the second part of duodenum. Colonoscopy visualizes the rectum up to the entire part of the cecum. But to visualize the jejunum and ileum, we have to use capsule endoscopy. So there are two uses of this capsule endoscopy. One is obscure bleeding. That is, we cannot visualize the source of GI bleeding through upper GI endoscopy or colonoscopy. We have to do capsule endoscopy. And next is the suspected Crohn's disease of the intestine, because the commonest part of the GIT involved in Crohn's disease is ileum. So screening colonoscopy is one use of diagnostic colonoscopy. For an asymptomatic individual, it is suggested to be done every 10 years to pick up any colonic pathology like a colonic polyp or colonic CA. If they have some high risk, that is a prior inflammatory bowel disease like ulcerative colitis or Crohn's, or if they have familial adenomatosis polyposis, if there is a family history of FAP, it should be done annually. For FAP, it should begin at a particular age. There is another familial colonic syndrome, colonic cancer syndrome, that is HNPCC, hereditary non-polyposis colon cancer, also called as Lynch syndrome. Here, the colonoscopy is done every 2 years after 15 years of age. Okay, now coming to esophagus, we have three esophageal motility disorders. One is achalasia cardia, nutcracker esophagus, and diffuse esophageal spasm. This diffuse esophageal spasm causes a finding called as corkscrew esophagus in barium swallow. What finding we get in achalasia cardia is bird beak sign. That is, the distal part of the esophagus is narrow. There will be proximal dilatation because the distal meningeal plexus fails to relax. Esophageal cancer causes a similar sign called as rat tail sign. In bird beak sign, the distal narrowing of the esophagus will be uniform. In rat tail sign, the distal narrowing of the esophagus will be irregular. We have a new group of drugs next to even better than proton pump inhibitors, that is PCABs, potassium competitive acid blockers. Since they are competitive, they are reversible. They are not hit and run drugs like PPIs. So vonoprazan and fexupressin are the drugs. Helicobacter pylori is a very important infection which causes gastritis. It causes refractory acute gastritis, chronic gastritis. Chronic gastritis can lead to gastric cancer. And since it is an infection, there is always a lymphocytic infiltration of the stomach when there is a H. pylori infection. So it can lead to gastric maltoma. It is said that gastric maltoma reverses on treating only H. pylori. H. pylori can be diagnosed non-invasively or invasively. Non-invasively is by doing a stool antigen test, by doing a serology, urea breath test. Urea breath test is a sensitive and specific test, non-invasively. We can do biopsy, and endoscopically also we can do rapid urease test. So this rapid urease test and urea breath test are sensitive and specific tests. How will we treat Helicobacter pylori? There are so many regimens. Few common named regimens are clarithromycin triple, that is a PPI plus clarithromycin plus amoxicillin. Bismuth quadruple, where bismuth comes and metronidazole comes. Levofloxacin triple, load. Load is also levofloxacin, and doxycycline will be given there. So coming to dyspepsia evaluation, when in dyspepsia always look for alarm symptoms, that is more than 40 years, presence of anemia with dyspepsia, weight loss plus dyspepsia, GI bleeding plus dyspepsia, that is a melena or hematochezia or hematemesis, fever plus dyspepsia. Always we must do GI endoscopy to rule out stomach cancer, gastric cancer. Now gastrinoma should be suspected when there is multiple ulcers, diarrhea, and ulcers in unusual locations. Multiple ulcers, because gastrin is more, so it causes more ulcers. Excess gastrin destroys trypsin, so protein is not digested, fats are not digested, so it leads to diarrhea. And there will be ulcers in unusual locations. So if these are there, we should suspect gastrinoma. Gastrinoma is a part of MEN1 syndrome. So there will be family history of pituitary, pancreatic, or parathyroid cancer. There are two types of atrophic gastritis. One is chronic atrophic gastritis type A. A is for autoimmune. Type B, chronic gastritis or chronic atrophic gastritis, is H. pylori related. Now coming to small intestinal diseases. Small intestinal diseases cause diarrhea and malabsorption. One important disease to remember in malabsorption is celiac disease. So the key terms to remember here is there is gluten intolerance. The antibody which is seen is anti-tissue transglutaminase IgA. It involves the duodenum. Why this word duodenum is important? Duodenum is the site of iron absorption. So celiac disease, there will be iron deficiency. If you do a biopsy, there will be villus atrophy. So duodenum, villus atrophy causing iron deficiency. How will you treat? Gluten-free diet is the first step. We can use steroids. Now another infection which causes malabsorption is Whipple's disease. Of course, there are other infections also which can cause malabsorption, like Giardia. So presence of these worm infestations, we call it as tropical sprue. So these are some infections which cause diarrhea. Now coming to inflammatory bowel disease. We have two inflammatory bowel disease. One is ulcerative colitis, another is Crohn's disease. Let us differentiate them. Ulcerative colitis, smoking prevents the disease. Very important to remember. The organs involved here are rectum, sigmoid, and the descending colon, the left side of the colon. It is a continuous lesion and submucosal lesion. So since it is submucosal, it will not cause any strictures. Crypt abscesses are the pathological finding. Toxic megacolon is the complication. Crohn's disease is opposite to ulcerative colitis. Smoking increases the risk. Here the right side of the colon and small intestine is involved. So ileum is the commonest organ involved. Rectosigmoid is commonly involved in ulcerative colitis. Ileum is commonly involved in Crohn's disease. Skip lesions are seen. Continuous lesions are there in ulcerative colitis. Skip lesions are there in Crohn's disease. Submucosal involvement is there in ulcerative colitis. Here transmural involvement is seen in Crohn's disease. Because of transmural involvement, strictures are common. The pathological finding is cobblestone appearance. In ulcerative colitis, it was crypt abscess. And we have non-caseating granuloma. One of the diseases which causes non-caseating granuloma is Crohn's disease. Caseating granuloma, we know it is TB. The complication here is strictures because of transmural involvement. Don't confuse IBD, that is inflammatory bowel disease, with IBS. IBS is irritable bowel syndrome, which should be brought into the picture only when all other disease entities are ruled out. So we have a specific criteria, that is Rome 4 criteria for IBS, that is there should be abdomen pain once in a week for 3 months. There should be abdomen pain once in a week for 3 months, plus they should have symptoms related to defecation, that is symptoms can be increased or decreased with defecation. There should be change in the form of the stools or change in consistency of the stools, frequency of stools. This is the criteria for IBS. Mesenteric ischemia, remember the symptom is postprandial angina because it's a artery or venous related disease. Whenever we tell about malabsorption, we should have specific test. So carbohydrate, see point number 23. D-xylose test is the carbohydrate malabsorption test. 72-hour fecal fat estimation test is for fat malabsorption. One important disease causing fat malabsorption is chronic pancreatitis. Chronic pancreatitis causes two important diseases. One, it can cause Type 3 D, diabetes due to endocrine deficiency, and it cause exocrine deficiency. Sorry, it is 3C. It can cause exocrine deficiency where chymotrypsin is deficient, so it causes fat malabsorption. So we discussed about IBS. One antibiotic which is used to treat IBS is rifaximin. Rifaximin, we know, is a non-absorbable antibiotic which is used in hepatology as a prophylactic for hepatic encephalopathy, because it is being an antibiotic, non-absorbable antibiotic. When taken, it destroys the gut bacteria. So when gut bacteria are destroyed, those bacteria cannot convert the stool proteins into ammonia. So ammonia production is less. That is why it prevents hepatic encephalopathy. But now it is also used in rifaximin, especially to treat the diarrhea variant. So we should remember two important diseases which are used in cystic fibrosis as well as in constipation IBS. They are lubiprostone and linaclotide. Lubiprostone is a CFTR activator. CFTR is a chloride channel. So lubiprostone is a CFTR activator. Linaclotide is a guanylyl cyclase stimulator. Both increase secretions, hence they reduce constipation.